It's Mehmet Oz. Welcome to the AATS Postgraduate course on heart valve disease. And Dr. Öztekin Otto, who's local co-director, and the rest of our colleagues who are running this event. I want to talk to you a little bit about how innovation happens in medicine. Something I'm very proud about because at Columbia University, where I'm on the faculty, we spend a lot of time trying to advance new ideas. But the process is not just one person with one good idea. It's a system, a culture that has to support it. So I'm going to tell you the story of percutaneous valves. And specifically, although I was involved with creating the first company that makes the SAPIEN valve now, the percutaneous aortic valve, the TAVR device, my first real foray was the MitraClip, which you probably heard recently in a large New England Journal published study, was shown to reduce the chance of getting hospitalized by half if you had heart failure with mitral leakage and had the MitraClip. And if you had randomized to being in the trial, the chance of dying went down by close to 40%. So massive benefit. But how did it happen? Well, let me take you back to Bergamo, Italy, 20 years ago. I was at a conference. I was the second last speaker. We've all been there. The person after you is maybe the only person watching your talk. So the two people who were second to last, me, and the last person, Octavio Alfieri, were sitting in the room. And he shared with me an idea that he had been using in Milano, Italy, where he was putting sutures into mitral valves that were leaking. And the big breakthrough idea was the mitral valve doesn't leak like this all the time. It actually, if the leaflets just touch a little bit, they snap shut. So every time the heart's pressurized, it snaps shut these very thin leaflets. I thought, oh my goodness, that's amazing. That means that in order to take someone who has heart failure, for example, where the ventricle distension, dilation has pulled apart the mitral leaflets, you could take the anterior and posterior leaflet, get one little stitch there to hold them together just in one spot, and when the ventricle was pressurized, it would close the leaflet. It would close the leaflet. Well, that's got me thinking, if it's just one suture, and these people are so hard to take care of who have heart failure. We've all been there trying to fix mitral valves. It's difficult because these patients couldn't have a hernia operation, much less open heart surgery, where we have to go putting them on cardiopulmonary bypass and making sure they don't have complications postoperatively. I started thinking, well, maybe we can put that one little stitch in from the groin. There could be a percutaneous approach that might be effective. So on the plane ride home from Milano, Italy, back to New York City, where Columbia and New York Presbyterian Hospital are, I began writing the patent that ultimately became the base patent for the creation of this technology. And the idea was sort of simple. Putting a stitch in is hard because you can't tie knots, but I could put a screw in or I could put a staple in, something that would clip it, analogous to what we now today use in the MitraClip. Then when I got home, because I think my university is pretty good at stimulating ideas, which I think all of us can copy in whatever center we're at, my idea was looked at by my colleagues. They supported the idea that the patent was worthy. We actually were working in the laboratory on it, funded by the university and the division of cardiovascular surgery at Columbia. And then following that, we were able to create a company called eValve, that, again, the university and the hospital supported. And this was good because we actually hired a CEO, a technology company CEO in medicine, who was a female, Farrell Powell. And the only sad part about this story is that this wonderful woman passed away a couple of years ago. She died in a biking accident in Europe. A true tragedy and a loss to the field. But she'd already done so much to grow this space that it ultimately was a large enough company. Abbott bought it, and that's important because you want small companies to do the research, but big companies have to buy to do the large trials which are required. New York Presbyterian Hospital was able to do a lot of the early clinical work, and together with other large hospitals and universities began to do more and more of these MitraClip devices so that we were able ultimately to have a big enough clinical experience to do the pivotal trial to show how it worked. And I'm going to show you a video now because this is what I like doing on my show. And I'm on my set right now. I like showing people what I'm talking about. So when I explain it to the audience around the world, and the show's in 100 countries, this is the video that I'm showing your patients. I'm showing them the anatomy, the vena cava, obviously, and the pulmonary artery and the aorta over here. But of course, this device is implanted through the groin. So let's go to the videotape. The catheter comes up through the groin, up through the vena cava. And as it enters into the heart, you're going to notice something. First off, the mitral valve leaks oftentimes because the ventricle is being pulled apart. So the green is the leakage of the valve. And as that leakage gets worse and worse, it creates problems. So the way you deal with it is to put that catheter across the atrial septum, down through the valve, engage the two leaflets, pull together, and staple the anterior and posterior leaflet together so the valves look like this from the left atrium. This is important because when I first learned about the idea of putting a suture in, my fear was you'd create stenosis of the mitral valve. It turns out you make a huge figure of 8, where if the leaflets are flexible, it actually is able to allow as much blood through as is required. In fact, in all the cases that I've done surgically with a stitch, I've never had a mitral stenosis case, with one exception. That's not even questionable. So I began to learn a lot from this experience, and I've passed it along to folks on media, but I want to make sure that you appreciate that innovation is what makes medicine special. It's what makes our chosen specialty able to innovate and get better and better with time. And we never want to lose that magic of being able to work with each other, come up with good ideas, share the best concepts, and then get the support of our institutions and industry in order to be able to advance the course of medicine. Because remember, we have 4 responsibilities as professionals. The first responsibility is to make sure we take care of our patient as number 1. The second responsibility is to make sure that we stand on the shoulders of our colleagues and we advance the field. That's what this represents. We do have a responsibility to police each other, to make sure it's done right. And we have a civic responsibility, the 4th responsibility, to speak to everybody about what we learn, which is what I try to do here on the show. And I encourage all of you, whenever you learn things at these wonderful AATS postgraduate courses, take the lessons and advance them throughout the field, not just with the patient in front of you, but with your global community. I hope you have a wonderful time at the conference. Enjoy Turkey. It's the home of my ancestors, and I love going there every single year. İyi günler.